Okay, we're going to get started here. So if everyone would get comfortable and appreciate everyone coming in today. This is our first Monday roundtable, the first Monday of each month. NOWIC offers an opportunity for members to learn about and network on a particular topic. Today's topic is called Clinic Accessibility in COBRA. For those, again, not familiar with our organization, the National Association for Workplace Healthcare was formerly called the National Association of Worksite Health Centers, but we've expanded our scope to include not just worksite centers, but also all efforts in direct contracting for primary care and other types of services. We're an organization that assists both health plan sponsors like employers and unions, as well as the vendors and providers who support them. We offer education, networking programs like this, benchmarking, purchasing support, vendor information, advocacy, and resources for all those stakeholders interested in this area. And we have our own LinkedIn group. So encourage you to go to our website and LinkedIn group for more information. Just some other upcoming programs after this webinar. We've got later this month, rounding our direct primary care with employee wellness. In January, we join our partners, the World Conference Forum, and hosting the 2026 On-Site Employee Health and Wellness Center Summit in Las Vegas at Caesars. For next webinar in February is called Beyond the Launch, Driving Ongoing Engagement for Employer Centers. And then we have our own annual forum in St. Louis on April 8th and 9th, Employer Managed Healthcare Worksite Clinics and Direct Contracting. So please be sure to participate. Remember, if you're a NOWIC member, all of the programs, except for the in-person ones, are free to members, and you're welcome. Now, this is somewhat different than our webinar in that our roundtable format, we're asking everyone to briefly give us your name, organization, title, and overall responsibilities. Uh, there then will be a short overview of the topic by our content expert, and then we're going to go around and everyone it will be asked for their own experience and information, recommendations, or comments or questions. This is going to be recorded, so the link and the slides will be available to people afterwards. So with that, let me first go around the table before I introduce our speakers. So as I call your name, I'd appreciate if you just, again, identify yourself and your organization. So Dawn, let me ask you to start, if you would.
Dawn Carey. I am the Senior Director of HealthWorks, which is our on-site health centers with Purdue. We have about 25 across the country managed by Purdue. Been with Purdue about 12 years and new to Larry's group.
Thanks very much.
Sure.
Katie, thank you. Stephanie Eckerly? Stephanie?
I'm Stephanie Eckerly. I'm a partner with the law firm of Craig DeVault and work with National Association of Worksite Health Centers on various matters.
Thank you. Shelley Kilao? Shelley?
Yes, hello, good morning. So I am a corporate benefits manager. I oversee all of the well-being strategies for Huntington Ingalls Industries. We do go by HII. We are a defense contractor. We have two on-site health centers, and that's what I do.
Thank you very much. Thomas?
Hello, this is Thomas Joe with Pfizer. I'm a national director for employers and really focus on population health initiatives with large employers.
Thank you. Deanna?
Hi, Deanna Han. I am a director with SSM Health at Work for our employer services and on-site near-site clinics in
Thank,
Wisconsin.
thank you. Jennifer Conrad, introduce yourself, please.
Conrad, I work with Breakbush Brothers. We are a further processor of chicken. We have 5 different states that we work within and 3 on-site clinics within those 5 different states.
Great, thank you. Kendall Rosemeyer. Kendall, introduce
Yep,
yourself.
Kendall Rosemeyer with Chief Health. We run direct primary care clinics privately in Minnesota and Wisconsin. We currently have 4 clinics that we operate in addition to corporate wellness programs.
Thank you. Michael Kaufman, introduce yourself, please.
Yeah, thanks, Larry. Good afternoon, everybody. Dr. Michael Kaufman. I'm the corporate medical director with Eli Lilly and Company, and we operate a network of on-site employee health clinics in the U.S. and internationally. So it's good to see everybody. Hi, Stephanie. Hi, Katie. Good to see you guys.
Thanks very much. And Rebecca Kohler, if you'd introduce yourself, please, Rebecca.
Yes, I'm Rebecca Kohler. I'm with Northern Buckeye Health Plan. I rep Director of Client Services. We have on-site clinics at our school and public employer locations.
Great, thank you. And lastly, I'll introduce our speaker for today, Catherine Katie Stowers. Katie?
Yeah. Hi, I'm Katie Stowers. I am a colleague of Stephanie's at Krieg DeVault. And my area of specialty is in ERISA and employee benefits, particularly related to health and welfare plans.
Great.
Thanks for having me today.
Katie, I'll turn everything over to you then.
Okay. Okay, well, just to kind of get us started, I put together this list of the issues from a health and welfare standpoint that can come up with worksite health centers. And it sounded like we've got a mix of both employers and providers on the call today. So good mix of folks. And some of these questions we get pretty regularly, and some come up in more of a tailored way. So first, let's talk about ERISA's application. So ERISA is the federal legislation that governs retirement plans and health and welfare plans. So it's broadly applies to all retirement plans and health and welfare plans, unless they're sponsored by either a non-federal municipal employer or a church. Underneath of ERISA are the obligations of COBRA. So to the extent that a plan is subject to ERISA, it's also going to be subject to COBRA if it provides group health coverage. So, and really that's defined pretty broadly to mean any type of medical care, except there is a small exemption in ERISA for the rendering of on-site first aid to employees. So most clinics, as they're currently offered to employees now, are broad enough such that they are providing medical care that would make them subject to ERISA and COBRA. Under HIPAA, interestingly, there is an exemption for an on-site clinic from direct compliance with the privacy and security rules, but that's primarily because you're subject as a healthcare provider, and the clinic provider will be subject to HIPAA as a healthcare provider. And then one that comes up very frequently now is compliance with the IRS rules that regulate high deductible health plans and allow individual employees to be able to contribute to individual health savings accounts. And the reason why this comes up a lot is because we don't yet have any exception under ERISA or under the Internal Revenue Code related to first dollar coverage. And if an on-site clinic provides care free of charge or not for a fair market value fee, then it would be considered to be disqualifying coverage and would make a high deductible health plan not qualified and make individuals unable to contribute to an HSA. Now, there's been a lot of talk in Congress about amending the IRS rules to allow that type of coverage. And we did get a very limited exception for on-site primary care, direct primary care in the Big Beautiful Bill Act. But as of right now, if your clinic provides anything that's outside of preventive care coverage, you do have to make sure that you're complying with those IRS related rules for high deductible health plans and HSAs. And then finally, under the Affordable Care Act, fortunately, on-site clinics do qualify as accepted benefits for purposes of the mandate and the required benefit provisions. So if services are, usually somewhat limited in an on-site clinic compared to a full-blown health plan, that's okay. You don't have to worry about getting in the way or getting sideways with the ACA. But you do have to include the value of health coverage on W-2s, and this is for any employers with 250 or more W-2s issued in the prior year. And so your clinic should be factored into that overall value of health coverage when you do that W-2 reporting. So I don't know if now we want to open it up to questions from the group about these various topics.
Okay.
I
Are
can
we,
get into
is
more
there,
details if you all want.
yeah, I mean, is there anything else you want to add to these or anything new developments that people need to be aware of?
I don't think so. I think this list is pretty comprehensive in terms of the um, compliance issues that are related to these types of health centers from a benefits
Katie.
perspective.
Yeah, Katie, this
Okay.
is Stephanie. The one thing I thought you might want to talk about a little more is the one big beautiful bill and how we're waiting on more guidance there for that new exception.
Sure, sure. So, yeah, as I mentioned, under the One Big Beautiful Bill Act, there was a provision in it that said direct primary care is exempt from compliance with the IRS high deductible health plan and HSA rules. But as of right now, how you define direct primary care is um, it's pretty challenging under that definition. So they're supposed to be issuing regulations to help clarify exactly what that means. It does look like from an initial reading that if a health center provided care beyond just direct primary care, that it would not qualify for that exemption. So it has to be a pretty limited service offering in order for that to work. But again, we're hoping to get some clarifying guidance on that will maybe expand on that a little bit and make it more flexible.
Great. Okay, so what I'm going to do now is go around the table and ask everyone if they have either questions for Katie, information to share, experiences, etc. So, Shelley, let me ask you to unmute, and if you have any comments, questions, or things to add.
So we have a very, very small portion of our population on a high deductible plan, and they are our most remote division. So our two shipyards um, that have our on-site do not have a high deductible plan, just thankfully for us. So it did come into play, and we did, go through the exercise when the waiver had expired, and we did, go through that. But thankfully for us, it doesn't come into play too often, although we are hopeful that, at some point we do not need to manage that, and we do fully support, the removing the barriers of a high deductible plan for our on-site because we would love for them to play much nicer together. But for us, it's just something that we track, and we would love, like I said, to support removing those barriers, but it's not a big challenge for our populations.
Shelley, one thing you mentioned was the waiver that expired. And I think you're talking about the COVID-19 related legislation that waived the cost of telehealth as an exception to the IRS rules that you could provide that telemedicine without any sort of cost sharing. Is that right? Yeah.
Yes.
That has actually been made permanent. That was in the One Big Beautiful Bill Act as well. So if an employer wants to allow telehealth or telemedicine and just cover that cost without requiring an employee to make a payment, that is permitted now.
Correct. Yes. We went through that exercise.
Yeah.
And then we did go through all of the different services that we provide in our on-sites with the high deductible plan as well at that same time. But I don't, it doesn't impact us except for the few that do live near our on-sites that work for our third tech division. So it's not something that impacts us, as it does impact a few employees, but our two shipyards, we do not have high deductible plans.
Gotcha. Well, let me just add a sidebar regarding the fair market value fee. Many employers try to determine what should that fee be and how to go about doing it. And in our recent survey of employers and plant centers, we found the average fee. Some are as low as $10, some are as high as the network provider rate, but the average fee across the country is only $30. And our understanding is as long as you have some documentation that says we have determined a fair market value fee to be this dollar amount, that's all you need to meet the requirement. Also, and all the consultants and attorneys and vendors and employers that I've talked to in the last 12 years, no one has ever been penalized for not having the fair market value fee. Now, there is some concern the administration would start looking at the fiduciary responsibilities of employers, and as part of that, under ERISA, to see whether you're complying with the fee. So, while there are a number of employers, about 25% we find in our membership, that don't charge anything at all because they believe are only offering preventive care or wellness, we always recommend you charge some fee. And you can, again, you can determine whatever that might be. And some employers do it as a fixed fee, like I said, $30 for any HSA employee who gets something beyond first aid and, at the center or wellness. Uh, Others charge on a scale depending upon the type of service offered. So there is a lot of flexibility here, but we, as was said earlier, we are making an effort to try to change that and make primary care and chronic disease management, behavioral health available before the HSA deductible.
Right. And I
So
work
we,
with a lot of employers, Larry, that are charging some type of fair market value fee. And really it's all over the map in terms of amount, like you said. The philosophy really is, you know, under IRS direct guidance, it says the fair market value fee should be what an individual pays in an arm's length transaction in the market. But we know that these high deductible health plans can have networks that discount what's charged. And really, this is just, you know, we've looked at it almost like the clinic is its own narrow network. And so you're able to discount the fee based on, you know, some calculation related to the cost of providing those services.
Gotcha.
so we
Yeah,
do
thank you.
charge a fee. We charge $40, but then we have various, we also have offer PT and we've offered various services. So when we went through that exercise, we were really looking at what Medicare charges in the area. Um, and that's what we had based a lot of our fees on.
Yeah, that makes sense.
Yeah.
Okay. Thank you, Shelley, for
So we
sharing.
really try to go with the lowest possible because,
Mhm.
again, we want it to be the best value for our members.
Right. And
Right,
most
thank you.
employers do that. They either want it to be no charge or a low charge because you really want to incent people to come in to the worksite health center instead of going out into the market.
Exactly.
Yeah.
Okay. Dawn Carey, comments, questions, things you want to experience?
Self off of mute here. I just had one question. To be honest, probably haven't looked at my W-2 in a while, so I probably should look at that. I probably should make sure that our company is reporting it, as noted here at the ACA exemption. But I did have a question in regards to telehealth and the high deductible health plan. Has there been any discussion or any understanding in regards to telehealth? We offer telehealth here for $0 if you are under the high deductible health plan. So I didn't know if you had any
Yeah,
comments on
that is permitted. And it doesn't have to just be preventive. It can be any type of visit that's appropriate for telehealth.
Yeah.
It is now permitted and made permanent, that exception to the HDHP HSA related guidance.
Yep. And we are one of those $30 markers that Larry had mentioned. That's our fair market value is $30. So
Okay, thank
that's
you,
good
Dawn.
information. Mhm.
Thank you. Kristen Rohr, Kristen, any comments, questions, or kind of experience you want to share?
No, I think we're covering and in compliance with all of these various different regulations. So
It's always good news, right?
yeah, yeah.
Great. Okay, thanks very much. Deanna Hahn, Deanna, comments, questions?
No, not really. I just do very much appreciate the updates on the HDHP and HSA compliance and all the efforts of this group and others to try to make that change. So to release that one last barrier for these clinics.
Yes, that would certainly be nice.
Thanks very much. Go ahead.
One thing, one question I get a lot, and I know we haven't gone all the way around the room yet, but I get a lot of questions around COBRA and how do you really incorporate a clinic into a COBRA offering? A lot of employers don't want former employees coming back on site, right? It's just kind of an awkward situation. You do not have to charge a separate COBRA premium and have people separately elect the worksite health center. It can be just part of the medical plan offering. And then oftentimes it goes a little bit unnoticed from a clinic and an employer perspective because people don't realize they can come back. There's nothing in the regulations that would say you have to specifically enumerate it out. But I know that can be an issue with COBRA.
Great. Thanks for sharing. That's important. We've not heard about that before, at least I've not. So maybe we'll post that. Dee FL, Dee, comments or questions?
No, I'm with Kristen on this. Going through them all, it is comforting to know that we feel like we address them. And the last question about COBRA is what we've been focusing on recently, like you said. And so that's very good to hear. I'm glad to hear you articulate that it can be a part of the plan and still be kind of, you don't have to necessarily broadcast it specifically or what have you. So thank you.
Thank you, Dee.
Yeah.
Jennifer Conrad, Jennifer?
Hi, I don't have any questions at this time.
Okay. Kendall Rosemeyer, Kendall, comments or questions?
Nope, nothing at this time. Thank you.
Okay. Melanie Small, any comments or questions?
Just echoing what everybody else said, I appreciate the information. One thing I'm wondering about is whether you have any sense of timing on getting clarity on what direct primary care is, like how it's defined.
We really thought that was going to be issued in October, but so far the regulations have not been issued. So I know it was a priority as announced with the big beautiful bill, but as of yet the guidance has not been issued.
Okay, thank you.
Hey. Michael Kaufman, Michael, comments or questions?
Yeah, thanks, Larry. I'm happy to say that we have been knee deep in this now for the better part of the last 2 years or so, having completed creating an ERISA plan for our on-site employee health clinics, coming up with discernment around HIPAA and whether or not we're a HIPAA covered entity, coming up with fair market value and a formulation to calculate that fair market value charge. By the way, we've settled on kind of the $20 mark for things that aren't preventive, aren't occupational health in nature. We've worked through the nuances of COBRA, as Katie just mentioned, where we really don't want former employees coming back to our securely restricted on-site employee health clinics. So I feel like we're in pretty good shape as all this goes. I do think the one area, and I know we've had some conversations with Katie and Stephanie on this, is around the application of the fair market value charge, right? So generally we would say that charge has to be applied for anything non-preventive, non-occupational in nature. But I think what we see a ton of in our on-site employee health clinics, which in any other industry might fall into that personal care bucket, that personal health bucket, it's around infectious disease, colds, runny noses, sore throats, those sorts of things. And maybe this is a little bit more of an industry-specific question, but the 21 CFR 211.28, right? That's the FDA rule that basically says employees must report to supervisory personnel any health condition that may have an adverse effect on drug products. So that applies to manufacturers. So I look at that from kind of a public health lens and say, well, it may be like a personal health condition, cold, runny nose, but because it may have such a big impact on our sterile manufacturer product, I want to treat that more like a public health condition. And because that federal code says I have to see somebody and restrict them if they pose a threat to our sterile product, I want to treat that as an occupational covered visit to the employee health center and not charge them fair market value for that. It's generated a fair amount of discussion with our attorneys, but I think we can justify doing that based on the fact that the employees are required to report to us, and of course the supervisor is going to say, well, go to employee health and let them check you out. Without having researched that, any thoughts around that, Katie?
Well, I have never looked into this, but it sounds very defensible to me that would be more like an occupational health related treatment.
Yeah.
I think you could make that case to the IRS based on that statute or that regulation.
Yeah, thanks.
Yeah.
Thank you, Michael. Rebecca Kohler, comments or questions, Rebecca?
No, nothing at this time. Thank you.
Okay, Thomas, Joe, Thomas, any comments or questions?
No comments or questions. Good to see it's positively trending, but great information.
Okay.
Yeah.
Stephanie, any comments or questions from your side?
Yeah, hi. My only comment, not so much questions, because frankly, I usually go to Katie with questions about ERISA and COBRA issues, but my comment would be on HIPAA. One question we're getting a lot from clients is, does even the healthcare provider that's providing the services qualify as a covered entity under HIPAA when they're just providing on-site care, let's say just occupational care? And so I just want to remind everyone on the call to analyze whether, if you are a healthcare provider on the call or you're contracting with a healthcare provider, that healthcare provider should really be looking at whether they're conducting standard transactions under HIPAA. So, for example, if they're only providing occupational health services that are directly reimbursed by the employer, they may not be conducting standard transactions. If they're doing primary care that's just directly reimbursed, they may not be. But if they are sending electronic transactions for claims processing, whether by a third party payer or even for some certain like PBM transactions, they may be. And so I know Katie touched on the HIPAA privacy and security exemption. But that's a little different what she talked about than what I just talked about too. And so there's a lot of layers with HIPAA. The other thing we've seen some of the on-site clinics run into is maybe they're not actually conducting healthcare standard transactions in the sense that they're not, for example, submitting third-party claims via an electronic standard to Anthem or Medicare, but they're acting as a business associate to the health plan, which then can impose some of the same HIPAA standards as a business associate. So just lots of nuances there on the HIPAA application side too, in addition to what Katie talked about that we have to deal with.
Great, thanks very much. There was an issue that was raised. It's not so much, I guess, a legal issue as it maybe it's a contracting issue. So Stephanie or Katie, maybe you could help as well. One of our members said they're starting a new clinic. They have HSAs, and they're wondering if what happens to that fair market value payment? Does it go back to the employee in their HSA account? Does it go to the employer? Does it go to the vendor? Does the vendor then reduce the admit fee for the employer based upon that? Is it like in generally having a copay for services for everybody? Is there a recommended approach or approach you shouldn't take?
Yeah, that's a great point, Larry. I've seen it done all of the ways you described. So where the payment is used to reduce essentially the provider or the employer's bill from this clinic provider to account for those payments, or the payments are just provided back directly to the employer by the third party provider. Either way works. Where this can get a little more complicated is in making sure that employees are getting credit for whatever it is that they're paying toward their deductible and out-of-pocket maximum. So that's where those transactions, like Stephanie mentioned, might come into play, where you're actually sending claims. Some employers will send $0 claims or to the TPA in order to make sure that people are getting credit for those deductibles.
Whose responsibility is that? The employer or the manager of the clinic?
To send the claims?
Yeah. Mm-hmm.
It would generally be a clinic provider.
Okay.
Would you set up a feed between the clinic provider and the TPA so that that information is going there? Because the employer wouldn't really have that information.
Gotcha.
And Larry, typically when that happens, and I'll defer to Katie on like how that flow works. But when the third party clinic provider is dropping $0 claims, we usually take the position, although it may be a conservative position, but position that that is a standard transaction then, because it is an electronic claims processing transaction, even though it's $0, which pushes you into the HIPAA covered entity realm if you're the healthcare provider for that on-site clinic.
Okay. All right. Does anybody else have any questions that they'd like to ask before we close our roundtable?
Yeah, Larry, this is Kendall from the Chief Health. Say, I just had a couple questions recently come up, and this is maybe not in this realm, but since somebody's an expert here in ERISA potentially, they were asking about qualifications for who they can include in their clinic. This is their clinic solely. And so there was some comments brought up about fair and equality of those people who are on the health insurance plan if they were to open it up to other employees or other employees' families who are not on the plan. Is there any feedback with regards to some things we should be concerned about with that? The employer is obviously paying for this, but because it's part of their health plan, it kind of raises a red flag of if you open this up to other employees and families that are not on the plan. Is there any concerns with that? Or defining,
Yeah, I'm sorry.
I said, or defining a group of people that can use the clinic that are not on the health plan.
Yeah, from a benefits compliance perspective, the issue there really can be if you're making it broader, making your eligibility for the clinic broader than the eligibility for your health plan. You have to make sure that you have essentially that documented as a different eligibility class, or I mean, it's still a health plan, so you still have to worry about being in compliance. The real complication though can come about with COBRA. Because those individuals, whether they're full-time or part-time or however you're distinguishing them that aren't on the health plan, would be required to be offered COBRA. So you would have to give them a separate COBRA offering for only the health center.
Yes, and they currently do that as well.
Yeah.
Yes. Okay. Sounds good. Thank you. Appreciate that.
Sure. I mean, those are really the most significant issues with that. That's a great question. I'm glad you brought that up.
Great. Thank
you. Other comments or questions? If not, Katie, Stephanie, thank you so much for your time today and help guiding us through this often quagmire of efforts and issues. Anything you think going to come down the road in the next year or so that employers and their partners need to look at or be prepared for?
I would say only keeping our eye out for any new legislation that will help us with the HDHP HSA issue. I think that's the most likely thing to continue to be on the legislative agenda.
Okay.
Yeah, Larry, I guess on my front, kind of aside from benefits, but going back to the HIPAA issues, the HIPAA rules were amended. And I'm sorry, there was a proposed security rule, and we're waiting for the final security rule to come out from HHS. And if that does, that's going to impose a lot more stringent requirements upon HIPAA covered entities and business associates. For example, right now, encrypted email is optional or what's considered addressable. It would be required under the new rule if it came out as in the proposed rule. And then for substance use disorder services, there was a final rule that came out quite some time ago, and the compliance date for that is beginning of 2026. So all covered entities need to be updating their notice of privacy practices and if they're providing substance use disorder services, and for on-site clinic providers or employers, the EAP sometimes will fall under a substance use disorder service covered by Part 2 that requires those more stringent privacy regulations. And then just all the new data security requirements, like Indiana has a new law becoming effective January 1st, 2026. So I would say that's where we're getting a lot of questions right now, is from those that are offering the substance use disorder services, and they're just generally, for that, if the new security rule comes down and is finalized, the cost and the effort that it's going to take for healthcare providers and employers to comply with that. So that's kind of on my radar from a non-benefits perspective.
Great. Well, thank you all very much. Have a great Thanksgiving and hope to see you at an upcoming program. As I said, this will be
Thanks so much.
recorded and this will be sent out to all those who participate as well as available to the NOWIC members. Thank you again. Take care.
Yep.
Stay safe.
Have a great day, everyone.
Thanks, Larry.